Welcome to week one of the Implementation Science Reading Course, the 2024 version. This is the 6th year of the reading course at Northwestern, and we are thrilled that you've joined us. We had record registration this year, almost 100 participants that will be participating across 10 discussion groups. So thank you very much for making the time to be here. I'm Sarah Becker. I'm the director of the Center for Dissemination and Implementation Science, and I'm joined today as a presenter by the exceptional Corey Bradley, a recent recruit and new team scientist at the Center for Dissemination and Implementation Science as well. And we have the pleasure of speaking with you about shifting your focus, an introduction to dissemination and implementation science. So let's jump in. We have an ambitious agenda for the next 30 minutes or so. We are going to start with a public display of gratitude to give some thanks to those that have really helped this reading course to be what it is today. We will then briefly review our course logistics. Then the meat of our time together will be really introducing you to some of the fundamentals of implementation science with an eye towards the week one readings that you all hopefully have read before today. And then we will briefly highlight a resource that might be of use to you as you engage in this course. And then we will spend our final 20 minutes or so together in our first discussion groups. So I have to publicly thank a massive and exceptionally talented team that made this group possible this year. The faces on your screen now are all the people that have been integral to the planning for 2024. These folks will be participating either as discussion group leads, as committee members that helped us to develop the curriculum, or as guest speakers. So hopefully you will see these friendly faces throughout the meetings as we participate together. I also wanted to specifically shout out Kira Di Clemente, Sarah Helseth, and Miranda Olson, as they have really done a lot of the heavy lifting and logistics for coordination of this year's group. So I wanted to publicly thank them. I also want to thank Dennis Lee and Miriam Rafferty, as well as Hendrix Brown and Nanette Hanna, as they were some of the original pioneers of this group back in the day with J.D. Smith. We really would not be here without them. This group started with 17 people in a small conference room, and now, as you can see, is about 100 people strong, meeting virtually. And the exceptional growth in implementation science is really a tribute to them and their exceptional foundational work. I also want to publicly thank NewCats, which is our Northwestern CTSA grant, as well as the Center for Dissemination and Implementation Science, which are providing funding for this course and the administrative support that it requires. I also want to thank the Bridges program, otherwise known as the Prevention Science Methodology Group, which was started by Hendrix Brown, which has done a lot of the work forming the curriculum for this back in the day. This year, two names that you should definitely know are Emma Litta and Jordan Viernes, and they'll be doing a lot of the administrative support, assigning you to groups, posting all of the resources on our SharePoint after each meeting, posting the recordings, and we just could not do it without them. So a huge thank you to Emma and Jordan for the administrative lift. We also like to acknowledge that the work we do and the folks that are here would not be possible without the land that we are residing on, and that this campus sits on traditional homelands of people of the Council of Three Fires and multiple tribes and tribal nations. And that this was a site of trade, travel, gathering, and healing for more than a dozen other Native tribes, and is still home to over 100,000 tribal members. So we're very grateful for the land that this group resides on. All right, so our course objectives. We are rooted in a reading that is by Pedek and colleagues that is hyperlinked in your slides, and these slides will be available to you after this course. Our goal is to help you to achieve a set of beginner level competencies. So if you click that hyperlink that's in the slides, you're taken to a reading of expert derived competencies in the field of implementation science that are divided into beginner, intermediate, and advanced. Our goal is for you to leave this course with beginner level competencies. And today we're going to introduce you to a few things. We're going to start to introduce you to some implementation research terminology. We're going to help you to differentiate between what is and what is not implementation research. We're going to briefly differentiate between implementation research and some other related areas, such as efficacy research and effectiveness research. We're going to try and inspire you by identifying the potential impact of doing dissemination and implementation work. We'll briefly touch on the range of expertise needed to conduct this work, And we're also going to introduce you to the need to be operationalizing and measuring health equity throughout implementation research. So a bit of an ambitious objective, but many of these objectives will be repeated throughout the course. All right, so now I'm going to turn it over to my partner in science, Dr. Bradley, who's going to help us walk through some of the course logistics for this year.
Thank you, Dr. Becker. It's great to present with you and great to meet all of you. It's kind of my first introduction in ways to our community here at Northwestern in this kind of setting. So I'm really excited and a little nervous, but it's okay. I'm going to work with you together because you may be a little nervous too about all the things you could learn. I don't know. But one of the things I want to say is for sure that I've come into implementation science in the last 4 or 5 years, and it in a lot of spaces feels like family and community and teamwork. So we're going to introduce you to these ideas and borrow your expertise and your insight to help us build the knowledge even further. Let's look at the next slide. So we do this by the readings, using the readings that are included and linked on the syllabus. You'll have 2 to 3 classic kind of articles that give us the staples, the meat and potatoes, and then we'll do some cooking in our didactics and in our conversations, and some supplemental articles that are available for you. Something you might want to pick up on based upon the conversation that we've had and interest that you've identified, and then articles that are denoted by an asterisk will provide some contextualization for our 2 case examples that we'll be using in our discussions. And then what you can expect in the didactic, they'll be co-led by NU faculty around 30 minutes to bring you into a basic pragmatic understanding of basic pragmatic methods that can be used across settings, populations, and disease states. And then you'll have copies of those slides within SharePoint. And then the maybe even more exciting part is the interaction that happens as we build knowledge together. You're getting introduced to the concept so that we can have shared language, but the ideas will be developing and advancing further together. And there'll be about 10 folks approximately in those groups. They've been designed based on shared interest. They're co-led by your discussion group leader. I'm one of those. And then peer discussants. And so you'll have a role and an opportunity to help lead as well, and link to the other examples in our from your own work to the readings. And we hope you'll bring that. Pose at least one question when you're in your groups, and raise points that inspire, confuse, or interest you. This is me again. So this is the heavy part, right? What we expect from you. Pretty please bring your whole self. Be prepared, like commit to 7 of the 9 sessions to your best ability, readings before class or skims, and sign up as a peer discussion leader for at least 1 week. If you're camera ready, and even if you're not, if you can get a little camera ready, we'd like to see your face and be able to interact in that kind of way. And keep the syllabus with NU colleagues unless you want to share, and please just let us know. And if you find that these are a bit tough for you and your responsibilities have shifted, maybe think about joining us again. You're more than welcome to join us.
Awesome. So thank you so much, Corey. And now we're going to jump into the meat and potatoes, to use Corey's words, of what is implementation science and what do we mean by a shift in focus. So in lay terms, implementation science is a field of study that studies proactive and intentional methods around bridging the gap between what we know in terms of public health and medical knowledge and what we actually do in terms of public health and medical practice. And that bridging of the gap is done with a relentless focus on both intention and equity in terms of eradicating disparities and ensuring equitable access to effective treatments for all. And what you see in this visual is that under this bridge are actually multiple gaps that need to be addressed in tandem. And I'm going to briefly talk about those over the next few slides. First, I just want to situate that we've intentionally called this group the Implementation Science Reading Group, and not the Dissemination and Implementation Reading Group. Yet our center has dissemination in the title. So what exactly is the difference between dissemination and implementation? Briefly, we like to think of dissemination research as research that is designed to increase the demand for effective treatments, or health services. You can think about it as a study of the targeted distribution of information or materials to a specific audience, but the end goal of increasing their knowledge and awareness of treatment is to increase demand for services. Implementation research, on the other hand, is the scientific study of the use of strategies to integrate specific effective services into specific settings in order to improve patient outcomes and benefit population health. You see that those definitions are in quotes, and that is because these are the definitions used by the National Institutes of Health. And the implementation research side is really all about increasing the supply of effective treatments in community settings. Why do we need to do this? I love whenever I talk about implementation science to share what I call an aerial image that I took of the health system. And what I'm really showing you is a picture of the Grand Canyon, because in the United States, the health system is incredibly siloed and fragmented. And I like to make the point that we're not looking at one singular gap, but we're looking at multiple gaps in tandem that combined form a chasm or a canyon of great proportions. So some of the specific gaps that we want to help you to learn to address. The first is the gap between the care that is available in community settings versus the care that could be available if we were to use our best knowledge. This is what we call the public health supply gap. This is very well documented. So what you're seeing on your slide now are visuals of Institute of Medicine landmark reports that document this enormous gap between the quality of care that is available and the quality of care that we have. It's also been documented over the past 25 years and actually replicated multiple times that there's a 17-year odyssey between when we typically identify priorities for research funding until we actually influence practice. There's an alarming statistic that you might have heard that it takes 17 years to turn only 14% of research to the benefit of patients. So clearly, there's not enough supply of effective, high-quality treatments in community settings. Part of the reason for this is that we tend to do things in a very linear and slow approach. We tend to first look at, is there a relationship between a target and a typical intervention? Then we look at, could this intervention work under very ideal circumstances? Then and only then do we look at, does it actually work in the real world? And then and only then do we think about how to actually implement it. What we want you to do after this course is be inspired to actually consider implementation from the outset, because we believe the only way to accelerate the very slow and leaky pipeline and that 17-year odyssey is to be using these methods throughout the translational continuum. Another gap that's important to think about is the gap between those people who actually need an intervention and those who access any treatment at all. This is what we could call the demand gap. What you're seeing on your slide now are just visuals for every 10 persons with a substance use disorder, only 2 will receive any treatment at all. For those with a mental health disorder, only 5 out of 10 will receive any treatment. For those with physical disabilities, only 7 out of 10. And the level of unmet need is greatest among those with lower education, lower socioeconomic status, and from racial and ethnic minority groups. So clearly we have huge problems also with the demand for effective services. And I like to emphasize here that I don't mean demand in a judgmental way that people don't want treatment, but I also am referring to demand as reflecting people's ability to access care. So when we talk about the demand gap, that also includes a number of structural and systemic barriers to care that prevent people from accessing the care that they need. Finally, there are also gaps between the expertise that we need to do this type of work and the methods that we know and are readily available to be deployed. So one example that we're sharing here is just an analysis of some of the landmark funding from the National Institute of Health to address the opioid epidemic between 2015 and 2019. This was a record amount of funding put forward, and an analysis of that funding suggested only 1.5% of all of the projects were actually studying how to implement things that we know work. And this is greatly at odds with feedback from the director of the National Institute on Drug Abuse, who recently said, we have all the tools we need to actually address the opioid epidemic. What we don't have is people's ability to access them and to get them out in community settings. So we also don't tend to invest in the work that we need to, and we don't have enough expertise. So that is what this course is all about. We want to help you to learn primarily to address the implementation gap or the public health supply side gap. We're also hoping to build your capacity and your expertise and to teach you the methods that you need. We will briefly touch on that public health demand gap in week 8, but that is not the primary focus of this course. You'll mostly be learning about public health supply, and we will be building your expertise and your methodological strength. All right, so how are we going to do this? We're going to do this by changing up the status quo. So in the status quo, you are probably well trained to think about effective health services and their effect on patient outcomes. What that ignores is a whole lot of context in between. It ignores the setting where that treatment's being delivered. It ignores the external policies. It ignores the leadership environment. And it also ignores the characteristics of the thing that you're implementing. It also majorly ignores the how. How are you going to get people to actually deliver that effective service in a specific setting? It also ignores a host of outcomes that might be important, like is it feasible for people? Can they do it with fidelity? Is it acceptable to them? What is the cost? It ignores a number of service outcomes as well, like is it safe? Is it equitable? Is it patient-centered? All of those things in the middle are the core of implementation science, as is the context around it and the methods used to do this work. So this is what we're going to be talking about in this course today. To put this really simply, we are going to be trying to help you to learn a couple key concepts. And this is from Jeff Curran, who has a beautiful article where that's called Implementation Science Made Too Simple. And basically, for the rest of this course, when we talk about an intervention, a practice, an innovation, you might hear us refer to that as a thing. That is a thing that you are trying to get people to do. Implementation is getting people to do that thing. Effectiveness research, which you're probably all pretty familiar with, looks at whether that thing works at equitably improving people's health. Implementation research takes it to the step of how do we help other people to do that thing? Something else we'll talk about, you'll hear us use the phrase determinants, contextual determinants, barriers, and facilitators. All of that means the same thing. It's basically conditions that make it harder or easier for people to do the thing. You'll also hear us refer to implementation strategies, and those in a nutshell are actions that we take to help people to do the thing. And you will hear us talk about implementation outcomes, which is how much, how well, and how equitably other people do the thing. So I realize I just threw a lot at you. I realize it probably feels a little bit like drinking from the fire hose, but that is kind of the nutshell of what exactly is implementation science and some of the key gaps that we're addressing in this course. It also tends to be well aligned with the mission of the Center for Dissemination and Implementation Science. And now I'm going to turn it back over to the exceptional Dr. Bradley to really sink our teeth a little bit more into some of the key readings that you read in week 1 and how these concepts apply. All right, so Corey, take it away.
Excellent. Dr. Becker, you made it sound way too easy. So everyone take out your pens. It's time for an exam. I think you have all the information you need. So I want to start here, and I really appreciated your statement about disrupting the status quo, and this is what we intend by saying that we want to a shift in focus. And one of the words that phrases I particularly use is to shift the gaze. And so you would see in intervention research, for the most part, the thing is what is in full view. Our colleagues have developed a really nice metaphor that pretty much kind of compares intervention research a bit more like portrait mode on your phone camera. And so you're hyper-focused on testing a promising health intervention. That's what's in front of you. You know, when you take a picture, it's all about you in the camera, right? So that thing. And then the whole delivery system that supports that intervention is a little more shadowed. And in research terms, that's because the delivery system is controlled and less frequently measured. But in shifting the gaze, the focus for implementation research is different, like landscape mode of your phone. And the thing comes into view really more connected with all of the other pieces in that picture. There's less blur, so that your attention turns to all the things that are happening in the interaction with the thing and get the whole experience. And you see that the mirror is dirty in those selfie photos, right? Like all of those pieces, which ultimately better defines that thing that we're studying and appreciating how it comes into being, how it comes into view and into operation, and how we define that. So let's advance a little further. This is from the Bauer article, and provides a little more if you're accustomed or familiar rather with intervention trial intervention trials, what's that distinctive difference, right, between intervention trials and implementation trial designs? And so your hypothesis changes from efficacy, effectiveness trials to implementation, where previously we're looking at the thing beating the control condition. And in implementation, the thing is what's being implemented, and we want to study all of the aspects of that. The population that's included. In your efficacy work, we don't really want people with a whole lot of problems. I remember looking at, I have hypertension, and I was like, all the studies are, you can't have any other kinds of conditions, right? So that's not really realistic in ways. Your effectiveness will include most patients. In implementation, that unit of observation broadens. For your outcomes, we're asking, does the thing help patients under ideal conditions? In effectiveness studies, does the thing help the patients in less than ideal? And then in implementation, did the providers, the clinics do the thing, and how well is how we're evaluating the outcomes in our science? For intervention, the efficacy is going to be heavily probably generated and driven by research staff and those resources. Your effectiveness trial, you'll be working maybe more so with folks who are implementing and the clinicians and maybe hired into the study. In implementation, we're thinking about the implementing team and all of those folks that are involved in that space. As far as context goes, your efficacy, we want to shut that down to the extent, right? The trial should be ideal. In the effectiveness studies, we're trialing within real world context. And then in implementation, we want to actually emphasize that real world context and thinking about how we generalize these ideas for multiple kinds of contexts. The research support in efficacy studies is pretty extreme and more intense, but it gets it gets a little more limited for effectiveness and implementation trials. But I would say that your team expands and who's involved in that. And we do a lot of participatory work and implementation research. And you'll see there's an emphasis by which we bring the concepts and realities of equity, advancing equity in the work. And then as it relates to validity, internal validity is more important than external validity. Then effectiveness trials, external validity, more important than internal validity. Implementation research is really fun. We get to color all outside of the lines. We create our own validity. And that's not really true. I'm kind of exaggerating, but less controlled in that kind of way as we shift that gaze and focus. All right, next slide, please.
All right, and I think I'm jumping back very briefly here. So this reading by Lane Fall, our own Renad Betis was the senior author, and this is a really nice visual depiction of thinking about the flow of research and when effectiveness research can maybe shift into implementation. And so if you want to locate yourself on the implementation subway, if you will, you can ask yourself a series of questions of, has the treatment that I'm studying shown efficacy? And if it hasn't, you can still be thinking about implementation science principles as part of your design. The next question is, has it shown effectiveness? And if it hasn't, you might do a typical effectiveness study, or you might actually be starting to lean into what we'll call a hybrid effectiveness implementation trial, which we'll talk about much more in future weeks. And you might also start to be thinking about a range of implementation science methods. In recent work, there's actually been a call from several implementation scientists that we probably are at a point where we can stop for behavioral treatments doing effectiveness research without any consideration of implementation, because it takes too much time to do effectiveness and then implementation. And we can be more efficient and be thinking about gathering really rich qualitative and quantitative data on implementation potential earlier in that pipeline. We're actually going to return to this in our discussion groups today and challenge you to locate yourself on this subway. And next, I'm going to turn it back to Corey for some of the rich discussion about some of the additional readings.
Okay, so you'll have to come back for more of this. And actually, this is a good opportunity for us to note that we've designed these sessions with an emphasis around health equity. And so we're expecting to be able to integrate that in multiple ways and in multiple sections. You'll hear it coming in and out. We don't think of it as its own distinct entity. But here's just a bit of a, kind of prep in that as we're kind of introducing implementation science. And the work from Bauman and colleagues, they help us to conceptualize what healthcare equity within implementation science might mean. And these guiding principles, one being that racism must be recognized as a fundamental driver of healthcare inequities. And so to appreciate, and you can click to that, click for me, Sarah.
Sorry, I froze for a second.
No worries. No, to appreciate that that article was written right around kind of the renaissance of anti-racism movement. So I think that there's an emphasis there on racism, but the idea is that we understand there are multiple kinds of conditions of oppression that folks deal with. And so you want to be thinking in implementation science to build your inquiry rooted in what are the causes of those causal relationships, if you're familiar with Lincoln-Felling and their fundamental causes theory. And so we want to explore that, and that's one way we approach healthcare equity. We think about equitable healthcare requires multi-sector partnerships. That's a guiding principle that brings us into equity. And not just that those multi-sector partnerships are mobilized, but that also that we think about multi-level approaches in accomplishing the things that we're not just focusing on the patient's ability or even just the provider's ability, but taking that panoramic view or that larger view. Context is central to healthcare equity. And in this way, yeah, that's fine to put that up. Yeah, I wanted to just share with you an understanding that the context is not just about the background, right? But it's about the interactions, it's about the influence, it's about what's modifying, what's facilitating, what's constraining that intervention and its implementation, and thinking about roles, relationships, and interactions. We're getting more into thinking about the assemblage of that given intervention and not just the thing itself, but also what all is connected to make that thing come into being. And then lastly, a principle that they suggest for emphasis is that we have equitable active engagement from our partners.
Sorry, keyboard problems.
No worries, no worries. It's okay for you to say, Corey, move on. So
my keyboard is sticking. Sorry, everybody.
This is a great article. I'm not sure that it may have been listed, but you can probably find that, just throw that in Google. Some key points and recommendations to respond around healthcare equity. And I underline care because one of the potential considerations is healthcare equity different than health equity when we're advancing population health, so to speak, and not just necessarily within the context of healthcare delivery settings. But the things that are important to remember, focus on reach from the very beginning, so that concept of access and reach, who are we missing, who are we including, and what power dynamics might be engaged in that. Design and select interventions from the beginning with implementation in mind. Who's going to use this, who needs to use this, and who's been excluded from use, and those showing up in high disparities. Implement what works and the strategies that reduce inequities in care. Develop the science of adaptation, critical and important within the implementation science study space, and doing that even through co-design and thinking about adaptation itself as an implementation strategy, and then using an equity lens for implementation outcomes. So that involves descriptive and explanatory studies where we're looking at the factors and the mechanisms of those inequities and seeing how we can address those through our strategies, our implementation strategies to achieve equity. Next slide, please. Building from that notion of the equity lens, and some people challenge the lens idea. I think it has probably some of the challenges, but I think it's helpful to think about, and it's particularly with this graphic from the paper by Shelton and colleagues, that I think also I would say that lens is a lens that also allows you to see yourself. So I would just add to that it's, I don't know if the word is convex, I can't remember my science terms, but you want something that allows reflexive for you as the researcher, and in the context that work is happening, also as you're using the different core elements and tools of implementation research that move us toward health equity. And in this case, these authors lay out a really beautiful kind of case and construction of using anti-racism concepts and literature. Implementation science is highly interdisciplinary, and that interdisciplinarity is a part of our advancement in equity, because we don't want this information silo. We want to be able to use rich sources of data data and insight and knowledge, including those lived experiences, to be able to see how we can configure stakeholder engagement, theories and models, evaluation and strategies, these things that you will come to learn. So you bring a lens as it is, and then there are other lenses that can inform the way that we see through implementation science to achieve health equity. I think, yep, there we go.
All right, so thank you so much. So that covers the readings. I'm going to go through the next two slides very, very quickly, and we will likely create this as a handout for you all. But one of the things Corey mentioned when talking about the structure of this course and the logistics is that this year we're going to be using 2 cases throughout all of the sessions to really help you to understand each of the elements of implementation science that we'll be introducing. And so those 2 cases, we've intentionally picked one health systems case example and one community-based example. The health system example that we will be revisiting throughout this course is an effort to implement screening and brief intervention for risky drinking across 10 pediatric trauma centers spanning 10 different health systems. The visual on the slide is one that we might refer to over time, but basically it's a phased approach of how one might implement, where you first identify a gap, then you select the thing in a partnered way, you assess your barriers and facilitators, and then you create a logic model and evaluate and think about sustainment. In this case, the gap was identified by pediatric trauma centers because they were mandated to implement screening and brief intervention, but rates of actual screening and brief intervention were very low in practice. And analysis also suggested that when it was being done in a racially biased way, that minoritized youth were being disproportionately screened, but not being provided the effective brief intervention. So these centers were highly motivated to implement this, but there was a lot of barriers and facilitators that emerged in a literature review and in a survey from the programs. And we used a structured approach to create a blueprint with them. And over the next 6 sessions, you will hear each element that we did. You'll hear the determinants, you'll hear the strategies, you'll hear the outcomes, and we'll really help you to build that. The second example you will hear us talk about was planning for the implementation of PrEP, which is a HIV prevention medication in local health department STI clinics. In this case, the gap was identified via a large national survey, and it was also identified through the National Ending the HIV Epidemic Initiative. And there was recognition that local health departments play a critical role in the scale-up of PrEP, but that actual uptake of PrEP was very low. Again, this thing was selected in a partnered way based on needs. There was a systematic approach to assessing barriers and facilitators and a systematic approach to creating a blueprint. And again, this will be revisited throughout the course. We just wanted to briefly introduce these cases so that if you see readings about PrEP or if you see readings about screening and brief intervention, you know why. Those will be denoted by asterisk on your syllabus, and will continue to help you to really put these concepts into action. All right, so we are about to break into our groups. We did amazing on time. Typically, we'll spend about 30 minutes on this didactic portion. This first week, it always takes us about 35 to 40 minutes just because there's more to introduce you to and to orient you to the course structure. One thing we did want to note is that the reading group discussions are really for you to discuss and engage in the readings. If you find that you are needing a methodological consult, we would ask that you not use the reading group space to do that, but that you instead visit our implementation science consult form. It can be found on the New CATS website, and there's also a link on the Center for Dissemination and Implementation Science website. If you go to their request a resource form, you will see a link to request a dissemination and implementation research consult. So if anything in your reading course discussion inspires you and you think, wow, I want to apply for pilot funding, or I want to infuse this into my grant, but you feel like you need more space than this group can provide, please feel free to use this resource. It is staffed by many of the team members that you will be meeting in this course. Many of the discussion group leads and presenters actually staff this service. It's led by Dr. Kelly Scott, and no request is out of scope. We are happy to help you. All right, so momentarily you will be assigned to one of 10 discussion groups. I want to give a shout out that this year, for the first time, we have 2 discussion groups that were created in partnership with another organization. There's 2 groups by developmental scientists that specifically joined this course together. And so that's very exciting. So that those groups will be led by developmental scientists, also in partnership with some CDIS faculty and other CDIS supports. But the other groups you were put together based on your answers to the registration form. So we tried to keep people with global health interests together, people with primarily clinical interests together, and also people that had health systems and shared quality interests together. So hopefully when you join your groups, you will notice some commonalities with people. For this week only, we're going to ask you to start off by introducing yourself, sharing your name and your role at Northwestern, some of the specific interests that brought you to this group, and to please situate yourself on the implementation science subway. In future weeks, we will assume you know each other, so we will jump right in. One thing we do want you to do from a housekeeping perspective, we're going to ask every person to sign up for a peer discussant role. We're going to put the link in the chat, and we'd ask you to pick 1 week that you will sign up to be the peer discussant. That means that that week you come with a discussion question or an example from your own work to help stimulate discussion. We do have a couple questions for you to consider today, if time permits. We would challenge you to think, based on the readings, what some of your thoughts and fears or anxieties about diving into implementation science research might be. And on the flip side, what might be some of the potential promises of using a robust implementation science as it relates to your particular research area of emphasis. We are also curious what questions you have about implementation research as a tool for fostering equity at this point that you hope to get answered by this course. And then we just want to announce that the slides and video recordings will be shared on SharePoint. And prior to the next readings, you'll get an email reminding you of what the readings are for week 2, and with that link to the SharePoint. We will not reconvene back in this main group. So you will be assigned to your breakout groups and we will break from there. So thank you all so much for making the time to be here today. We look forward to seeing you over the next additional 8 sessions. And we hope that you found this informative and that you have a wonderful time with your groups. All right, and so now at this point, Emma and Jordan are going to work some magic and start to assign people to breakouts.